Good afternoon, and welcome to this briefing for the House Health and Government Operations Committee. This is a virtual committee briefing. Consequently, I ask for your patience if we encounter any technological or streaming issues. This briefing is being streamed on the General Assembly's YouTube channel. Committee members will be muted throughout this briefing. If you have a question to ask after the presentation, please use the raise hand function, which is located either underneath the participant list or on the right side of your screen, or under the reaction bar at the bottom. I will call on delegates to ask questions. Please adhere to our usual committee rules of one question and one answer from the panel, not one question and one answer from each individual panelist. Please keep your questions shorter than your expected answer. Today, the committee will be briefed on Maryland's total cost of care waiver by representatives from the Health Services Cost Review Commission, the Maryland Hospital Association, and Medkite. It is our goal to conclude this briefing close to 2 o'clock. As a reminder, the full committee will be having bill hearings at 2:30. We will begin with a panel from the Health Services Cost Review Commission. Please begin your testimony.
Good afternoon, Mr. Chairman and members of the committee. My name is Katie Wunderlich, and Madam Chairwoman, I see you as well. My name is Katie Wunderlich. I'm the Executive Director of the Health Services Cost Review Commission. I have with me today my colleague Megan Renfrew and the Chairman of the Commission, Adam Kane, and I'd like to let Mr. Kane say a few remarks first before I dive into this quick overview.
Certainly.
Thank you. Sorry, I just dialed into the wrong Zoom, but now I think I'm in the right place, so thank you very much. My name is Adam Kane. I'm the current chair of the HSCRC. Thank you, Katie. On behalf of the 7 volunteer commissioners and 60 dedicated staff, we're pleased to present this briefing to you. Thank you to the committee for your interest. It's a very important topic and a key part of health policy in the state of Maryland. I'd also like to thank our healthcare partners, the Maryland Hospital Association, Medicite, the Nursing Home Associations, and others all have been working not only tireless to deal with the pandemic, but also to advance the policy and purposes of the Maryland model. As many of you know, Maryland's in a very unique position, having this model is the only of its type in the country. And we're demonstrating some significant success by reducing unnecessary hospital utilization, funding and promoting care transformation, improving quality. And we hope to continue to create new programs that engage more and more of other healthcare, non-hospital healthcare providers. Having said that, we're managing through the pandemic, which has been challenging for all of us in healthcare, including we appreciate the support of the committee members and the executive branch through the pandemic. But through the pandemic, we've been able to provide some more support for our healthcare system and our hospital systems, over and above what the federal government has provided to the hospitals and other providers across the country. And we're proud of that and continue to work closely to monitor the situation with the pandemic to see any additional support we can provide and any other helpful role we can play. Beyond the pandemic, we still have some challenges in the model to continue to reduce unnecessary utilization, as well as furthering our investments in community-based and population health to meet state goals and CMS goals. And as you'll hear today in the presentation, we are particularly proud of the beginnings of trying to do some new programs for non-hospital providers to really get more alignment across the healthcare system between hospitals and non-hospitals. And with that said, I'll turn it back over to our very capable Executive Director, Katie Wunderlich.
Thank you very much, and thanks for that introduction and to set the tone for this briefing. I have a few slides I will go through quickly. I do want to be able to get to any questions that the committee may have, and I also do want to recognize our care partners that are also on the panel, the physicians, specialists, and hospital providers. This really does take the work of the whole spectrum of healthcare providers to advance the goals of this model. The next slide just shows a little bit of the overview. I wanted to do some introductions, an overview of the commission, and some details on the Maryland Health Model, our progress, and how we are moving forward. The next slide is just a background of the HSCRC. As you all know, we are an independent agency situated within the Maryland Department of Health. However, we do retain an independent nature to our commission based on the rate setting that we do for both Medicaid, Medicare, and private commercial payers. Our traditional role is in hospital rate setting to ensure cost and quality on the hospital side. However, as the model has evolved, so has the role of the commission to lead health reform efforts in the state to improve health, focus on better health outcomes, and reduce total costs of care. And so I think you'll hear in this briefing today how that evolution has occurred. We're really working on some very exciting and innovative ways to better align our delivery system to focus on reducing health disparities, improving health, and lowering costs. The next slide reminds the committee about the structure of the Maryland Health Model. So the Maryland Health Model is the name for what we are calling the total cost of care model now. On the left-hand side, you'll see it's buttressed by two main components. The all-payer hospital rate setting system, which is in Maryland statute. It's been in Maryland statute since the 1970s. And that does require payers to pay HSCRC approved rates. And then the other side is the agreement with the federal government through CMMI that waives Maryland from the Medicare payment rules that govern the rest of the country. So those are the two main components of our Maryland Health Model. And together they provide a number of strengths and benefits to Marylanders. The first and foremost is controlling hospital cost growth, not only for Medicare, but for Medicaid and commercial payers, consumers, and businesses. We also, because it is a system that has been in place since the 1970s on an all-payer basis, has set the stage for equity in payments. It guarantees equitable funding of uncompensated care, which shares equally the burden of caring for patients that are underinsured and uninsured. It funds a number of other common healthcare goods like the Health Information Exchange operated through by CRISP. Our Health Information Exchange is one of the most robust and user-friendly in the country, and really proud of the work that they have done to advance connectivity for our healthcare providers. And then finally, graduate medical education and nurse training. All of these are funded through the all-payer rate setting system. They all bring benefits to Marylanders that's not available in other states. The next slide shows the progression of Maryland's system. So as I mentioned, we've had this all-payer rate setting system in place since the 1970s, but it has evolved over time, and we intend to continue evolving it as healthcare evolves. So, in the beginning, we were under a volume fee-for-service basis. However, we've evolved over time to a more value-based approach. 2 points of time I'll point out on this slide. 2014 to 2018 represents our first model contract with CMMI, the first time that global budget revenues, population-based revenues were put into place for hospitals. And that really turned the tide and turned the incentives for hospitals from one that was meant to churn and produce a lot of volume to produce revenue, to one that focuses on patients, keeping patients healthy, focusing on preventive care, focusing on partnering with upstream and downstream providers to improve health for patients and to reduce the need for high cost acute care services. The box represents the 2019 to 2028 represents the point of time where we are now on the total cost of care model. This is still an agreement that we have with CMMI, and it builds on the success and the foundation of the all-payer model. It expands to add a focus not just on hospital cost and quality, but also on population health, care transformation, health equity, and looking at cost and quality, not just on the hospital side, but on the non-hospital side as well. The next slide shows some of the components of the model that help to drive success. The first and foremost is that hospital population-based revenues. Those are the GBRs. And that really is the vehicle through which hospitals are reimbursed and target their expenses throughout the year. Under the total cost of care model, we've expanded that to include additional hospital quality requirements, incentives, and responsibilities to keep total cost of care at a lower growth. The second component is additional payment and delivery system reform. This was also something that we had started to develop under the all-payer model, but that we are really ramping up now. And you'll hear more about care transformation initiatives and care transformation from the other two panelists, but we're really trying to foster care transformation across the healthcare spectrum. So we're really trying to connect hospital and non-hospital providers so that patients can be, there can be a streamlined sense of care for patients. The next two components are new to the total cost of care model and really critical to the success of the model. The next one is the Maryland Primary Care Program, which my colleague, Mr. Gene Ransom, will go into more detail about. It's really a critical component of connecting patients and making sure patients are able to manage their health at the primary care level. And then finally, population health and health equity is another component of the total cost of care model that has expanded since the all-payer model. And this really encourages programs and provides incentives for improvement in statewide population health and health equity measures. Speaking of those statewide population health and health equity, the next slide shows our statewide integrated health improvement strategy. This is an agreement that we have with CMMI for additional quality goals under the total cost of care model that speak to that population health, health equity, and care transformation. It really is Maryland's pathway to reducing disparities, improving population health, and enhancing care transformation. And one that I think I'm really proud of the work that not only the state, but our private sector collaborators all came together to agree on some focus areas and shared goals that improve quality on the hospital side. Care transformation, the gray side, is connecting other providers. And then third, the green bubble is total population health. And so this really is Maryland's, it's a set of goals that advance health quality, population health, and care transformation across the hospital side, the spectrum, the healthcare spectrum, and then on those total population health goals. And there is additional information in the appendix on those different goals, but they do speak to how we are trying to work as a system to advance the goals of the model. And the three population health goals are really important ones that are represent areas of long-standing disparity and disease burden that Maryland has been, working at. But in putting them down as goals, we hope to focus our attention across the state on reducing diabetes incidence and burden, reducing opioid dependence and opioid mortality, and then finally, maternal child health. We have a goal to reduce maternal morbidity rates and to decrease asthma-related emergency department visits. We have a few, the next slide shows a few of the special funding programs we have, in addition to GBRs, where hospitals are able to use their own GBRs to better affect their community. We also are able to earmark statewide revenue for directed and coordinated activities. And so below are a few of these examples. These programs are intended as seed funding and are intended and expected to develop and become sustainable over time. I'm going to highlight a couple that you may have heard about. In fact, I know you've heard about it, have had some briefings on, but our Regional Partnership Catalyst Grant Program, which if we go to the next slide, is intended to support those population health goals within SIHIS. And it's intended to support and promote hospital and community-based partnerships. The first two funding streams that we identified were for diabetes prevention and management, and the second one was for behavioral health crisis services. It's a 5-year program. The next slide shows the number of partnerships that have been developed. There were 9 proposals altogether that were funded, 6 diabetes partnerships and 3 behavioral health crisis partnerships. It represents over 30 hospitals participating in one of these regional partnership programs, over 150 community-based partners. That is a requirement and an expectation that this is not just a hospital-based program, but that to truly have success in reducing the incidence of diabetes and addressing behavioral health, community connections and community partnerships are critical and vital. The next slide shows maternal child health funding, the third funding stream to support the goals of SIHIS to reduce maternal morbidity and decrease childhood asthma. We're partnering with Medicate and the MDH's Public Health Administration for that program. So those are some of our special funding programs. Again, ways that we are able to use the Maryland Health Model, the all-payer rate setting model, to earmark and direct funding to specific and directed community health needs and population health goals. The next slide shows, this is just for your reference, this shows model performance through the end of calendar year 2020. We have met all of our goals, our financial and quality goals through 2020. However, you'll know the COVID pandemic happened in the middle of 2020, and so we are really looking at making sure to monitor what our results have been through 2021. The results for 2021 should be available usually by April or May after the year closes. I do want to just spend a couple of minutes on where we are going in the future. The next slide shows a timeline of the total cost of care contract. It's a 10-year contract, but really an 8-year performance period. We are currently in model year 4 in 2022. The model goes through 2026, and then there's a transition period. But I just wanted, this is just for purposes of everyone understanding what the timeline is. We do have some points with CMMI where they will do evaluations, where they will assess our SIHIS goals, where they will assess our savings rate and financial targets, where they will assess how well we have developed care transformation in the system. And by model year 6 in 2024, that's really where we will, as a state, talk with the federal government about what comes next after the model, or after this total cost of care model. It's absolutely our intention and the intention of our stakeholders to continue the model because of the many benefits we have. But we will have a discussion about How long will that next iteration be? What will the terms and points of that contract be? Part of what will inform CMMI and the federal government on that decision on how to extend the model rests on some evaluations. I have 2 slides in coming up. The next slide are some evaluation highlights from the contractor from CMMI. And it does, we had a very positive first implementation evaluation that cited how the global budgets have provided financial stability for hospitals, how it's a strong incentive to transform care. We've delivered savings to the federal government. We've started on care transformation and identified population health and health disparity goals. So we're really on the right track in this implementation. However, it did also point out where there are still areas for improvement. The next slide shows some evaluation highlights on where we can improve. We can continue to reduce the total cost of care. Total Medicare spending in the state is still the highest of all states. So we still have some work to do there. We can still continue on our SIHIS, looking at population health, advancing better health outcomes and addressing health disparities in chronic diseases, and then continuing to improve on some of our quality measures. The next slide, though, as I mentioned, it is absolutely our intent to protect and continue the model because of the many benefits that it presents to the state, including those population health investments, health equity, financial stability it brings, the cost growth that is in place because of the model. So many benefits that we would like to protect for the state of Maryland and the investments that we've made. And then my last slide is just on some strategic positioning for long-term success. We have a lot of opportunities in front of us. We have an opportunity, as you'll hear from my other colleagues on the panel, to engage health providers in value-based reform, to increase value to patients, to improve health, to create programs that align not just Medicare, but Medicare, Medicaid, and commercial payers, to lead the quality and payment reform in the nation, and again, to leverage our system to address health disparities. However, there are also some threats that we are aware of and that we want to make sure we risk mitigate. One, some that you can't exactly mitigate, the unprecedented public health emergency. Another one is under-resourced state effort. So in order for the model to be successful, there needs to be a fully and well-resourced commission. There needs to be a good investments from the state and state agencies on our population health goals, investments from our private sector in attacking those goals as well. So there are definitely things that we have on the lookout that we're making sure to monitor and mitigate so that we can position the state for success. My last slide is just a review, and I don't need to go through it. I really am very proud of the work that the commission has done, its partners, hospitals, physicians, specialists, long-term care providers. This takes all of us together to move the model forward and to achieve success. We have a lot of opportunity to leverage in a very unique way healthcare resources for Marylanders. And be happy to take any questions that you all have, although I know there's 2 other panelists behind me. So thank you very much, and that concludes my remarks.
Thank you, Madam Director. We're going to hear from the other panelists because I think this really is a joint presentation. So we'll be open to questions from members after the other 2 panelists make their presentations. Next would be Bob Atlas, who is the president of the Maryland Hospital Association. Mr. Atlas.
Thank you, Delegate, and thank you to the chair, the vice chair, and all members of the the committee for inviting me to join you today to talk about the second most important asset of Maryland after blue crabs, the Maryland model. I'm going to try to be brief and not to restate anything that Ms. Wunderlich said so thoroughly. So I want to focus on the benefit, really the sort of the, what's the proof of concept here. We like to say that our model has three key values: equity, community, and value in terms of quality and economic value. And on equity, our model was founded on principles of equity, actually, over 40 years ago. In Maryland, all patients are charged the same amount for the same service in the same hospital. It doesn't vary depending on what one's insurance is. Whereas outside of Maryland, hospitals generally set rates on their own and negotiate with private payers. And it's all about market leverage and maximizing income. There's no cost shifting in our system and no two-tiered system of care. So our model promotes equitable access to every community. Every hospital in Maryland is in effect a safety net hospital. And we're able to ensure equitable access to care in urban and rural areas and everywhere in between. Second is community. Maryland hospitals are transforming care delivery not just to improve quality of care, but to raise up the health of our communities. The population health goals our state has signed on to under our model contract require us to partner and to invest upstream, sometimes before people even go to see a doctor and certainly before they visit a hospital. We know that to succeed at the higher levels that we're aiming for, we have to address social and environmental factors that impact health, and this requires partnerships in many ways. You may have heard that we had a meeting with the leadership of CMMI in the fall, and one of our health system executives who came from outside of Maryland before working here talked about there being a level of collaboration here that's unmatched in any other state. We've got examples of collaboration to address social determinants of health, such as the what's called GBRICS, the Greater Baltimore Regional Integrated Crisis System, focused on behavioral health intervention. There's also heavy investments in housing in Baltimore City, because we know that housing is probably the premier social factor in people's health and well-being. There are also many examples of programs to bring medical care and social support to patients where they are. We've had hospitals sending repair crews into homes to reduce seniors' risks of falling, or sending pharmacists into homes to help with medication reconciliation, or EMS to go in and check on patients who are high users of emergency care and perhaps keep them healthier and less inclined to rely on the hospital ER as a regular source of care. Hospitals elsewhere in the country may do some of these same things, but here they're happening at a scale that I think we all should be proud of. And lastly, value. Outside of Maryland, hospitals are able to generate revenue by growing their volume, and they're paid more when they do more. That's not true in Maryland. So functioning under fixed revenues with our growth tightly capped now for 8 straight years, our hospitals have cut unnecessary utilization, saving Medicare a lot of money in the process. And most importantly, they've improved patients' care and outcomes. Recent evaluations have documented this value delivered, as Katie Wunderlich just showed you. I just want to take a few minutes more, go on to the next slide, please. So I talked about no cost shifting, and I just want to illustrate that here. In the green area on the left, this is what happens in other states. Self-pay patients don't pay much of anything, of course. Medicare and Medicaid pay well below hospitals' costs. And so what hospitals do is they charge the maximum that they possibly can to commercial insurers. On average, that's 145% of hospitals' costs. Here in Maryland, the system makes it so that Medicare and Medicaid pay just about hospitals' full costs. And so commercial payers just pay a tiny amount more than that. So in a community where there's very little private insurance in the population, Medicare and Medicaid, as well as our scheme for covering uncompensated care, fill that gap. And that's why we can have stability in our rural hospitals and in our urban hospitals, and fairness. And in fact, that those lower rates that commercial payers pay make health insurance, health care much more affordable to people who get their insurance through their health insurance through employers or on the exchange. Next slide, please. And, you know, in this model, Maryland hospitals have made some very, very deep commitments. You know, those global revenue budgets, which HSCRC sets, that is a cap, not just on prices, but on the total revenue that a hospital may take in. That's unheard of, non-existent anywhere else. And we've managed to master how to do that in our hospitals that you won't find anywhere else in the country. Our hospitals also take risks for costs of care beyond the hospital. So when Ms. Wunderlich said something about, you know, we have costs, we have to bring down costs, total cost of care. In fact, our total cost of hospital care is actually quite low. It's our cost of non-hospital care that bring the total up some. And so in the latest iteration of the model, we've introduced that risk for, or increased the risk for non-hospital services that's on the shoulders of the hospital. We have very powerful quality incentives. A hospital's revenue can be seriously lowered or increased depending on performance on quality of care. That can't be overstated at all. It's very important, very valuable, and it really motivates our hospitals to get it right in terms of, you know, reducing hospital-acquired infections and improving patient satisfaction and a whole raft of other things. And lastly, through the as reinforced by the institution of the strategic statewide integrated health improvement strategy, we have hospitals committed to whole population health. As we always say, you know, keeping people healthy and out of the hospital is one of our main objectives. Keep going, please. And so, you know, we've generated real results. We've saved in the 7 years since we launched the all-payer model. Well, it's 8 years, but 7 years of measurement. We saved Medicare $2.5 billion in hospital savings, 1.6 billion looking at total cost of care. Again, because the non-hospital side has risen a little more than we'd like. We've created a setting where we have the lowest or second lowest cost to private payers in the nation, which benefits consumers as well because they have their cost shares. And so, you know, if the payers are paying less, the consumer pays less in their cost share. And we've had a much slower rate of spending growth in Medicare than in most of the rest of the nation. And so we have created and have been on a steady path to improving value. And we've also done many things on the quality front, reducing preventable hospital complications by more than half, and beating the nation on Medicare hospital readmission rates. Going on, just very quickly, you don't need to read these, you have a copy. But, you know, our performance is recognized by many writers and analysts. Back now a couple of years ago, Vox published this article saying, you know, Maryland may be the answer to America's healthcare cost problem. Next one. fairly recent opinion piece in the New York Times by the noted writer Elizabeth Rosenthal, who talked about her own encounter in a hospital. She lives in DC, gets most of her care in Maryland, and as she notes here, we're the one state that controls what hospitals can charge for services and has a cap on spending growth. And importantly, the director of CMMI, the agency that is the federal owner of our model contract, she has come out recently and very publicly said she's more in favor of promoting models that address total cost of care, like the model that we have in Maryland. And so, CMMI, one of CMMI's goals is to hold up Maryland as an example to other states to say, you should be doing innovations like this. And finally, also from CMMI, they released their own new strategy white paper in October. And one of the things they noted was that of 50 models that CMMI has launched since the agency was created by the Affordable Care Act in 2010, and of 50 of those models that have been evaluated, only 6 have shown statistically significant savings. And Maryland is one of those 6. And in fact, on a dollar basis, Maryland outstrips the savings levels of the others. And so CMMI has laid out a series of equitable outcomes that they are driving toward in how they launch new programs, and Maryland really checks the boxes on a lot of these things. And so, we are confident that we are delivering on what CMMI expects. But of course, they have the opportunity at a number of touch points coming up to make some judgments, and frankly, there are people in the federal government who might question ultimately whether this model ought to continue. And it's very important to us to keep this model. It has so many benefits to the people of Maryland. So on my final slide, I'll just sort of summarize to say, it's uniquely Maryland. It's uniquely successful. We get right what other states are getting wrong, and the people of Maryland cannot afford to lose this model. So we will appreciate everything that you can do from your perch to help us preserve and protect it. Thank you so much.
Thank you, Mr. Atlas. Let's proceed to our third and final witness on this panel, our only panel for this briefing, Gene Ransom, the CEO of Medkite. Gene.
Thank you. Thank you, Madam Chair and members of the committee. I really appreciate being here today. And I wanted to start by saying that Medkite strongly agrees with Mr. Atlas's testimony this morning, as well as Chairman Kane and Director Wunderlich's testimony. I'd also point out that while they're not on the panel, both of the nursing home associations, HFAM and Lifespan, and the insurers are actively involved in these projects. And I think it's really important for the committee to recognize the level of work and collaboration that's going on in this area, in this space. It's not that we don't kind of bump elbows sometimes or push around each other or disagree, but I think we all recognize that the value of this is so important that we need to work through our differences and work together to keep this in place. So you might say, physicians and the total cost of care, why are you here? And frankly, in the 70s, that question would have made a lot of sense. The physicians fought very much these changes that occurred when it happened, but over time, things have changed, and things really changed in 2019 when the state of Maryland entered into this new agreement with the federal government, because suddenly the cost outside the hospital, those long-term care costs, the physician costs, the other practitioner costs counted and mattered. Since that time, the physician community, kind of working through Medkite, has worked very closely with the HSCRC and the state to launch 2 key alignment programs, the first of which is the Maryland Primary Care Program. And the Maryland Primary Care Program, I'm not going to go into a large amount of detail because I know this committee has received other briefings on it. But essentially, it was identified specifically in the most recent contract with the federal government. It is a key element of the total cost of care contract. And it's one of the largest and most successful adult primary care advanced payment models in the country. Just from a number point of view, There are about 470 Maryland practices in the Maryland Primary Care Program. Those 470 practices represent about 400,000 Medicare patients that are receiving enhanced benefits as a result of being in the program. And those practices touch about 3 million Maryland patients. We're talking about approximately 2,150 practitioners who are signed up and enrolled in this in Maryland. So this is huge as far as magnitude and effect. The program has been in effect for the last 3 years, and essentially it sets up payment incentives for the physicians who are in the program. Those payments, and I've outlined them here on the slide, essentially give the practice additional money so they can provide services above and beyond what Medicare typically pays for to these patients. The services are around the quality measures that were discussed earlier, issues like diabetes, inequities, addiction issues, and its attempts to try to make sure that we can get folks who are the sickest, who need the most help, the help they need when they need it. Examples of the way that this money gets spent for patients: some practices do things like contract with Lyft to get patients to the office. Some practices use the money to add care managers who make phone calls when someone ends up in the hospital. There are all kinds of different ways and services that the physicians and hospitals who are involved in this program use to try to give a higher level of service and better manage the care. This program also helped with Maryland's response to COVID. And I think it's really important to understand that the infrastructure that we're developing here is not just for those 400,000 Medicare patients, it's really for all the patients in Maryland. With regards to COVID, and I have to give Secretary Neal credit for setting this up and Secretary Schrader for keeping it in place, there was a decision that was made that communications to clinicians was going to be done through the Maryland Primary Care Program. Medkite agreed to do CME for free, but we had all physician calls, and literally thousands of physicians were getting COVID updates at first on a daily basis, and then less frequently, but they're still going on today. In fact, we have one next week if anybody wants to come on. And literally clear communication to physicians about how to deal with COVID issues was done through the infrastructure created by the Maryland Primary Care Program. This was huge. And I think one of the reasons that you probably had less complaints from physicians than other sectors of the healthcare industry was the high level of coordination that was in place. This coordination was not just in developing and giving out clinical information, it was also and continues to be with the coordination of treatments like monoclonal and oral medications, and it was very helpful with the delivery of vaccinations. In fact, I had colleagues from other state medical societies calling me and saying, I'm hearing your physicians are getting vaccine and ours are not. The state of Maryland was able to deliver vaccines through the Maryland Primary Care Program to targeted physician offices so they could hit underserved communities or people with higher needs. And that was huge. The infrastructure that we're developing with the total cost of care contract ends up benefiting all of us. And that's just a key example. The Maryland Primary Care Program, though, is just really one of the alignment programs that we're going to be moving forward with to try to get folks that are outside the hospital system engaged and aligned with the hospitals under the total cost of care contract. The newer one that is launching, or actually launched 20 days ago or so, the Episode Quality Improvement Program is focused on specialists and proceduralists particularly. Essentially, the Episode Quality Improvement Program is a second physician program that will allow physicians to take some risk with regards to bundled payment programs so that they will manage them better and try to save money for the total cost of care. And in doing so, they can remain, they can actually help save costs and they can win as a result of sharing some of the savings. EQUIP, the Episode Quality Improvement Program, is totally voluntary and has no risk to the physician. There's only an upside. And essentially, the physician is responsible for their performance and needs to be successful. Another benefit of this program, which was developed in a collaborative public-private partnership with Medkite and the insurers and everyone involved, is that it is aligned specifically with Care First new episode payment improvement program. The benefit of that is that means that physicians who are attempting to manage bundles in certain specialties can do the same type of bundle with the federal program under Medicare that they're doing for their Care First patients. And hopefully, as time goes on, we'll get other payers as well on this program. In year one, we focused on gastroenterology, general surgery, orthopedics, neurosurgery, and cardiology. And the plan is that we're going to be working collaboratively to expand those specialties in future years based on need, outcome, and interest from different specialties.
If I may, Gene, can you let us know when you want us to flip slides?
Oh,
please?
yes, I'll do that. So
Thank
sorry, I'm on episode quality improvement program, obviously, with the 3 specialties. With regards to payment, episode value payment, flip the slide. Essentially, the physicians, again, agree to an episodic payment with regards to EQIP. So they're getting paid for the episode. A target price is set. And then if they can beat that target price by managing the cost related to that bundle, they can then have a winning at the end. And that's how the program works. Analysis of other CMS bundle payment programs have shown savings of 4 to 6%. We actually believe in Maryland, the savings possibility could be greater. You can flip the side again. Again, we worked closely with Care First with regards to EQIP to make sure there was alignment with their new episode improvement program. Unfortunately, with the Maryland Primary Care Program, alignment wasn't contemplated at the beginning, and we're trying to retrofit it in. We are working very hard to have Medicaid and others align with regards to Care First, with regards to the Maryland Primary Care Program. But we were fortunate enough or smart enough to think about that from the beginning with regards to EQIP. Closing thoughts, this second to last slide. The Maryland Primary Care Program provides a higher level of service to hundreds of thousands of Medicare patients in Maryland and has helped with the COVID response. It also helps with other population health issues like diabetes and BMI and addiction. It's one of the largest and most successful advanced payment models in the country. On a per capita basis, I don't think there's another primary care program that's larger. The newly launched Episode Quality Improvement Program is a new opportunity that includes proceduralists and will allow specialists to try to be in value-based programs. It's been created in an aligned fashion with at least one private insurance carrier and hopefully more, and should help us meet those goals, aligning the economic incentives of specialist physicians with the total cost of care. I really do think another really important point with regards to all of this is physician and other community practitioner involvement is key to the success of the total cost of care agreement. And secondly, we really have done, I think, a good job of creating a public-private partnership in this space. The Stakeholder Innovation Group is run by the Maryland Hospital Association and has vast representation across the private and public sector. And the Episode Quality Improvement Program subgroup is run by Medkite, myself. And again, it has representation from hospitals, nursing homes, and insurers. The key to us adding in the responsibility for the total cost of care is figuring out how do we economically align these other groups like physicians and nursing homes and others, and how do we make them all work together so we can better manage care and we end up with better results for the patients in Maryland. And I think it's a worthwhile project that I'm glad to be part of. Thank you.
Okay, if members wish to ask questions, it's now time to so indicate on the software. I was going to ask a question as to if this system is so great, why isn't anybody else doing it? But Mr. Atlas, at the end of your testimony, you gave us an hope that there may be an inkling of this. At least there's an awareness in the provider and the whole medical community about this. So good. Delegate Young, followed by Delegate Pena-Melnick, the first two. Delegate Young.
Thank you, Mr. Chair. I would like to address my question to Mr. Atlas. As we all know, the pandemic has exacerbated the demand for mental health patients with emergency needs. And it creates a demand for beds as well as emergency room space, which challenges your goal of reducing repeat visits. I know there have been a number of initiatives to have mental illness treated in a more effective manner, in a more effective place. But what do you see as the remaining barriers to getting mental health treated in other more appropriate areas versus hospitals?
Thank you for the question, Delegate Young. I state somewhat the obvious. We need more capacity, and to get that more capacity, we need the funding to be suitably sized and pointed. You know, we know that community-based behavioral health works, but it is always lacking in terms of resources and access to it. And so, you know, that would help a great deal. You know, many of our hospitals actually, you know, are involved in community behavioral health and supportive of that. It's just there's, you know, the reimbursement is poor, and the non claim-based funding is also lacking.
Thank you.
Delegate Pena-Melnick, followed by Delegate Krebs.
Thank you, Mr. Chairman, and good afternoon. Thank you, everyone, for the great information you're providing. I have a question for Katie Wunderlich, and I want to start by saying thank you. You guys are always very responsive. So I want to ask the question regarding the Consumer Standing Advisory Committee. We received some emails that this group has not been active and has not met for a while, for a couple of years. And as you know, that group was actually designed to help and assist the HSCRC with consumer-oriented expertise, and especially given that we are discussing this. Can you tell us when would that group be reconvened? When can it have a burst of energy? And when are they going to give some input regarding what you presented today? Thank you so much.
Yeah, and thank you, Delegate, for that question. Obviously, consumers are, you know, why we are all here to make sure we're delivering the right kind of health, making sure they're informed, making sure they are helping to lead the delivery system as well. So the Consumer Standing Advisory Committee was formed. We reconstituted that for the Consumer Standing Advisory Committee to work on community benefit activity and community benefit reporting. So actually the Consumer Standing Advisory Committee is now working on that project, on the community benefits project. We thought they had a good window of knowledge and insight into what needs are on the ground from the consumer perspective. And so we have convened the Consumer Standing Advisory Committee for that purpose. So that's how that group is meeting right now. We've put a hold on work group meetings in the short term because of COVID. So for the month of January and probably into the beginning of February, we're going to hold limited amount of work group meetings, but we absolutely do intend to continue having the consumers from the Consumer Standing Advisory Committee meeting around those community benefit issues.
May I have a quick follow-up, please?
Briefly, yes.
Thank you, just very brief. Will you be so kind and seek input from them regarding the total cost of care model? Because we got some emails that some of them would like to do that. It will be great.
Absolutely. I can follow up also with you, but we will renew our efforts in addition to community benefits, which I think is a really important way that hospitals and the model support the needs in the community through the community benefits that are delivered and the coordination that happens there. But absolutely, we will make sure to invite, solicit, and ask for advice and feedback from our consumers.
Thank you so much. I really appreciate you. Thank you, Mr. Chairman.
Thank you, Madam Vice Chair. Delegate Krebs, followed by Delegate Cullison.
Thank you, Mr. Chair. First of all, Jean, thank you for highlighting some of the positive outcomes that we've had this year with COVID regarding communication with Dr. Half and the primary care physicians. I mean, that's a positive thing. Sometimes we often focus on our opportunities for improvement, but that's a very positive item that I'm glad you brought to the attention of our committee. But Katie, I have a question, two questions in one, but on page 15 of your packet, on one hand, it sounded like everything was going well with total cost of care, but on this packet, it says total Medicare spending was higher in Maryland than other states, driven largely by higher hospital prices. So I'd like to understand what that means compared to the rest of the presentation. And then on top of that, a number of years ago, we were working on certificate of need changes, and there was a work group on that. And we did a few things changing certificate of need with hospice and a couple other things. And then the work group was supposed to go back, and this is prior to COVID, and come up with some other recommendations regarding the certificate of need. And now that we've been through the pandemic, obviously we've had a lot of changes with regarding beds and space and whatever. So is that still ongoing? So it's sort of two questions in one.
Thank you very much, Delegate. So to address your first question on total Medicare spend, yes, Maryland is a high-cost state. We've been a high-cost state. In fact, that was one of the reasons that the initial waiver was put into federal statute, was because Maryland's costs were high and were growing exponentially higher than the rest of the country's. And so the first iteration before CMMI's model contracts required Maryland to constrain the rate of that growth. So we were always still higher, but we had previously been growing very fast compared to the nation. So our what was the task put to Maryland was to constrain that rate of growth. Now, through the all-payer model and the total cost of care model, those continue to be the drivers to constrain growth. So we have guardrails that don't allow or that direct the state not to grow faster than the nation. We have some guardrail considerations, but that's the main tenet, is that we are trying to constrain our rate of growth such that perhaps we meet up with our peers over time. There's no expectation that Maryland, because we are a high cost state, because of our geography, our population, because of the medical education in the state, we will never be at the 50th percentile of all states. We will never be equivalent to Wyoming or a state that does not look like ours. So we likely will always be a high Medicare spend. What this report from Mathematical on slide 15 is showing is that while we have delivered actuarial savings to the Medicare program, we still are higher. We still have a higher baseline than the rest of the country. And so our goal over time is to continue to constrain the growth such that we come in line with some of our peers over a long period of time. So that's the short answer to that. The second one, yes. Oh, okay. The second was on the CON work group. I believe that work group was in conjunction with the Maryland Healthcare Commission that issues the certificates of need. I am not sure. I'll have to check on the status of the work group. Many things were put on hold during COVID just because of logistics and focus that, the focus areas that both the Healthcare Commission on issuing the emergency CONs for the hospital beds so I'll have to check back with you, Madam Delegate, on the status of that work group for certificate of need.
Thank you, because that could affect total cost of care as well. Thank you.
Absolutely.
Thank you, Delegate Cullison, followed by Delegate Saab.
The unmute button was struggling. And thank you all for fabulous work that you do and the report. I want to follow up on Delegate Krebs' question, and am I like totally off base here? But isn't part of the reason our spend is higher is we're actually reimbursing at higher rates? So it's our hospitals and professionals who are being paid at higher rates than in other states. um, overall through through the global budget processing. Is that right? So, and then I'm going to take a little license, and the chair can stop me if he wants to. The other thing I was wondering about is you sort of went very quickly over the threats to the program. Is there anything that stands out with you in terms of what we might be able to help with in terms of those threats? So those are my questions.
Thank you, Madam Delegate. So the first question, yes, you are correct. Mr. Atlas showed the slide where we ask Medicare and Medicaid to be better payers, pay more of their share of hospital costs. So you are absolutely correct in that our hospital per unit costs are still high. Now we have different incentives that help to bring down utilization. So overall spending can come down, but you are correct. We do ask Medicare and Medicaid to pay closer to cost so that our commercial payers don't have to make that up. So that's correct. The second question, Madam Delegate, was on the threats. And so a couple that I mentioned, one is an under-resourced state effort. And I think this is multifold. First and foremost, the commission that the HSCRC that helps to drive this, we need to make sure that we have a fully functioning and fully resourced commission. That is very important in order to make sure we have the analytic tools, that we can develop the programs that Mr. Ransom mentioned. The EQUIP program is a resource intensive. It took a lot of staff and thought resource to put the program together, to reach out to specialists, to identify the bundles. Those kinds of things take manpower and take investment on the state side. And so that's kind of first and foremost is a really important aspect. And then also other state investments in population health across state agencies. We've been doing our best to coordinate and leverage where other state agencies can help lean in on those population health goals. These also take investments, resource investments. So I would, mention those. The other threats I think, the other threats I think we can help to mitigate. One of the threats that I mentioned was misaligned quality and financial incentives. But those are things that EQUIP and MDPCP and other things are helping to bridge. And so we just need to keep our eye on how we can continue to align our incentives as much as possible.
Ms. Wonderlich, if I could just add another, that the committee has addressed over the years is when we have, excess capacity at different facilities and other areas where there needs to be a realignment in the services offered to the community, that causes a lot of turbulence. But it's important for the model to be successful, that the healthcare delivery system become more efficient and responsive to what is needed in the community. So that is going to cause some changes in what hospitals look like, what types of services are provided. And that's a lot of hard work and a lot of hard work with the community. And we just ask for, patience and flexibility and understanding of what the long-term goals are, which is to provide more effective services at, appropriate prices.
Yeah, thank you very much.
Thank you. Delegate Saab, followed by Delegate Hill.
Thank you, Mr. Chairman, and thank you, Ms. Wonderlich and Mr. Atlas and Mr. Ransom for the presentation. Mr. Gene, I have a question for you. Good presentation. I particularly appreciate the aspect of the public-private partnership. And what interested me was that Medkite's hard work on EQUIP and how close it seems to me that to what CareFirst wanted to do last year on a value-based payment. Obviously, Medkite killed the bill last year. Can you tell me or explain to me the difference?
Yeah, that's a very insightful question, Delegate Saab. Let me break it down because I think it is very much aligned. I think you're dead on. And let me also remind the committee, kind of relaying it to the last question, Remember, physicians are still on a separate payment model, and we're actually paid less than the rest of the nation, unlike the hospitals. So the question's all related to the hospital. But as a result of that, we are paid differently and we're on a fee-for-service basis. And Medkite has always supported value-based programs. The problem with the Care First bill, unlike EQIP and the Maryland Primary Care Program, but the Care First bill really was more addressing the EQIP type thing, is there were three big issues with this that we didn't like. One were a series of what I would call technical or procedural or smaller issues. That's like a big bucket. The second is the fact that there was a lot of risk in the Care First bill. And the third was the fact that there's no floor protection. There was no floor protection on the Care First bill. So comparing what Care First proposed last year to this year, if we look at it, and one of the things this committee did was it said, you guys need to go get in a room and work this out. And I'm telling you, we've been working on it. We've had a lot of meetings and we're getting really close. On all the technical kind of procedural stuff, we've worked all that out. So I'm not going to bore you guys with that because that's resolved. Those differences are taken care of. The two big issues that are left are the risk issues. So in EQIP and MDPCP, the risk levels that are allowed in the Maryland Primary Care Program, it varies on which track you're in, but it's about 5%. That's the amount of risk the doctors are taking. In EQIP, the risk percentage is 0. The initial Care First bill had unlimited risk for the doctors. Now, Medkite, Care First, and others, Mr. Atlas has been involved in this too, detail. We've worked out the risk issue. Care First has agreed to a 10% cap on the risk. So that issue is resolved in part of the negotiations. But that was a big deal for my members. We did not want unlimited risk. My doctors are in a fee-for-service world. They're in a different world. Taking unlimited risk for a small practice somewhere is very scary. So I think we've resolved that. And that was one of the reasons we were opposed to it last year. The last issue that we are not done on yet, but we're still working on, is the floor issue. So unlike the Care First proposal, which had no floor in it, and we have not reached a consensus, there's multiple proposals going back and forth, and I assure you, we're still working on it. We're going to try to get it done, and we're going to get it done. I feel comfortable that I want to get it done. But let's talk about the floor a little bit. So the floor is the guarantee that you get if you don't go into the value-based program. So for both EQIP and Maryland Primary Care, the doctor can say, you know what, I'm not going to do this. And the floor is the Medicare fee schedule. They know they're going to get that. It's a guarantee. So there's no problem at all. So there's a really solid floor in both of those value-based programs. In the initial Care First program, there's no floor at all. There's no guarantee. They could give you whatever fee schedule they wanted or tell you they don't want you to participate. So that is the last issue we're trying to figure out. We've made a proposal. Care First has made a counter proposal. We're hoping to get there. But that's really the reason why we weren't there. Medkite is committed to value-based care. We believe in the importance of this, not only for the success of the model, but also for, frankly, patients in the public health of Maryland. We think it's a good way to go when it works right. The key is, like with any program like this, you have to be careful and have protections for particularly the parties, like my members, who have less bargaining power, and more important than my members, the patients. You don't want situations where you create so much risk that a patient's put at risk. I think we're going to get there. I'm very optimistic. I think we're really close. We're down to that one last issue. And I really appreciate you bringing this up because I think it really ties in well to this issue. It shows the commitment we've made in the last 3 years working through EQIP with the hospitals and the insurers. And I think we're going to be able to do it on the private side as well with the Care First bill, hopefully this year.
Thank you. And thank you everyone for all you do. And thank you, Mr. Chairman.
Thank you, Delegate. Delegate Hill, followed by Delegate Bhandari.
Thank you, Mr. Chairman, and thank you all for your presentations today and for the work you've been doing over the years. I think this question really is best addressed to Katie. I noted on slide 15, the point you say Maryland has room to improve quality measures, including readmissions and potentially preventable admissions. And that leads me to the question. For the most part, the pride in how the model is working seems to be based on the finances. We're saving money, we're meeting financial goals. Do you have any information, studies that you can share with this committee that really speaks to the quality of care? And, you know, admissions and readmissions are fine. That's a marker, but that doesn't talk about whether patients are feeling as though they're receiving the quality that they were used to or have been expecting to receive. So do you have anything, or can you speak to that now?
Yeah, sure, Delegate Hill. Thank you very much for that question. we do have some quality, specific quality goals that we have around readmissions and reductions in complications, and we continue to make progress and improvement on that. I think the area that Maryland has the most work to do is under our QBR program, our quality-based reimbursement program, which measures in some parts consumer satisfaction. So it has a number of domains within our QBR program, but one of them is the hospital HCAHPS scores, which have historically, unfortunately, been low in Maryland compared to the rest of the country. I think, we as a commission, the QBR program is in our pay for performance program. So hospitals are rewarded or penalized based on their overall QBR score, which includes those HCAHPS scores. So we put it in our pay for performance program to try to incentivize that way. But I think you are absolutely right. There are some continuing perception issues with those HCAHPS scores. Some of that is derived from emergency department wait time to be seen, time to get through to a bed, to the throughput. And that's a really complicated and complex issue in terms of the emergency department. I think hospitals have been working at that. Right now during COVID is a particularly stressful and intense time in the emergency department because a lot of people are in the emergency department for COVID related reasons. But I think, at the end of the day, yes, you are right. We do have work to do to improve those quality scores. And I do think that's what we intend to continue working on. The hospital side of things is only one portion of those of quality. SIHIS is the other portion of quality that goes beyond hospitals, that does care transformation and population health. So we obviously have work to do to achieve the goals that we've set for ourselves within SIHIS as well.
Okay, so can you share whatever recent studies you have that do a comparative before model and over the last, even pre-COVID, so we can look at that and also see the specific items that you're scoring, because again, they may not be the best items to score. That would be helpful. Thank you.
Sure. I can follow up with you just as a quick connection. Our QBR program is based on and has to meet some requirements that are based on the federal VBP value-based purchasing program, value-based program. So we do have to keep it aligned, so we don't have full discretion to add or change. It has to mirror what's on the federal side, but absolutely we can provide you more information on what's in our QBR elements and some reports.
Thank you.
Thank you. Delegate Bhandari, followed by Chair Pendergrass.
Yeah, thank you, Mr. Chair, and thank you for great presentation. Absolutely, all payer rate setting is a healthcare reform measures, and we hope that the rest of the country will follow this. My question, before the question, I want to confirm if it is true that Medicare's participation is authorized by the Social Security Act, right? And it entitles the state hospital to over $1 billion per year in additional revenues from federal government. My first question is, how is that money divided among the hospital? And the second question is, this is a little bit bitter experience. If a patient is admitted to hospital in emergency, after a few days, the patient is discharged and he has to, for example, if the patient has a life-threatening disease, the hospital knows and they ask him to find the doctor on his own and find the appointment for all the tests. And it is already hard work for the constituents. It is too much burden to the family. Is it because the reimbursement rate is too low for Medicare? And what could we do to mitigate this situation in a life-threatening case? And I also went through this, and I would really appreciate if you answer this question honestly, because sometimes the hospital knows that the the patient is going through the life-threatening situation, but still they discharge and ask the patient to go through all the tests, even though test is available at the hospital.
So, Mr. Delegate, I will answer your first question, and then perhaps Mr. Atlas, you might be better positioned on the second one. On the first one, you asked about where the waiver from federal Medicare payment rules comes from. You are correct. Prior to the Affordable Care Act, our waiver from Medicare rules was in the Social Security Act, the Federal Social Security Act, that had a specific exemption for Maryland, as long as it met some certain conditions. When the Affordable Care Act was put into place and the Centers for Medicare and Medicaid Innovation was established, also in the Social Security Act, our waiver from those federal, from Medicare payment rules now falls under CMMI's discretion in our contract. So it's still embedded in the Social Security Act, but it is in a different way. Prior to the Affordable Care Act, we had a specific statutory, a specific call out for Maryland. Now it falls within CMMI, and we have to meet those contractual obligations to continue to have that waiver. There are a number of numbers that are thrown out. What is the waiver worth in Maryland? We actually, the commission undertook a process to benchmark Maryland and Maryland's hospitals and jurisdictions to similar jurisdictions around the country. And the results of that benchmarking study show that Maryland receives excess Medicare total cost of care payments more in the range of about 700 million. And really you have to think, because our system is 50 years old. So the way our healthcare system has evolved and developed in terms of where ownership and where different things are completely different in Maryland than they are in other states. And so when you just compare straight unit rates in Maryland versus others, it's missing the bigger picture and missing how our healthcare system has evolved. And so, our benchmarking shows that we are really more like about 700 million in excess total cost of care Medicare costs, and we intend to continue to put incentives in place to both control the growth and to get out some of those additional excess costs so that we are in line with our peers. So that is the first question. And Mr. Atlas, do you want to take a stab at that second one, please?
I'll try, as long as I'm not violating the chair's rule of only one panelist
Briefly,
answering.
briefly, please.
Okay,
We have a
so
full hearing.
as regards, it sounds like there might have been a specific case that was driving the question, and if so, I'd like to work with the delegate offline to understand what that was. In general, every hospital starts thinking about discharge at the time of admission. Hospitals now have large teams of care managers, discharge planners, who understand and address the needs for working with the continuum of care. We have many situations where we have what we call now hard to place patients, people who we know are ready for discharge, but there's not a receiving site that can take them on the other end, and so we're working hard with state resources as well as our private care partners to make sure that we can make those handoffs effectively. And we want nothing more than for every patient to have not only a good experience with the hospital, including the follow-up, but to have a good health outcome, including that post-admission period. We did talk about readmissions, and we get penalized for excess readmissions within a short time after discharge. And so, if that patient had a bad outcome, that would come back to penalize the hospital. And so, we're always working to make sure those handoffs and those post-hospital experiences are good.
Thank you, Mr. Atlas. Thank you. Chair Pendergrass, the last question.
Thank you, Mr. Chairman. First, I just want to say to staff, please defer the next hearing by about 15 minutes to give people a chance to get a break. Second, I'd be remiss today if I didn't say, and this is not a question, to all of the presenters and the agencies, groups that they represent, we are very lucky in this state. We were in real trouble in terms of Medicare, Medicaid, with the feds. And because of the work that's been done by all the participants, we're on a good path. It's not just the goodwill of your members, although that exists, but each of you has done a really enormous and important job sitting in the room, working with each other, and the HGO committee as well. I have to say that we have been supporters. We've been following along, trying to help move things forward. It's really important that good people can be in the room trying to make things work. And I just really want to say thank you to all of you. And with that, I will hand it back to my capable chair.
Thank you, Madam Chair. Thank you for the kind words, and not more importantly for the players and all the participants in our healthcare system, who we all have personal experiences with it, with that system, as we know. That concludes this hearing, and I assume the full committee is at 2:45, which is a 15-minute delay. We're awful close to that. Or do you want to make it 2:40, Madam Chair? Or is that?
Make it 2:40. Make it 2:45. Let's give people a little break.
The full committee will resume at 2:45. This concludes this briefing. Thank you all very much.